October 8th, the World Health Organization validated India as having eliminated trachoma as a leading cause of blindness in the country and around the world. While the validation was a long time coming and highlighted the convergent success of many endeavors around India, it also ironically served the purpose of reminding that the country still remains what has often been described as the blind capital of the world. One institution that has been at the forefront of repairing vision impairment and restoring sight to tens of millions of Indians for over 4 decades now is Venu Eye Hospital based in New Delhi. Founded in 1980 by a remarkably passionate and professionally successful ophthalmologist, the late Dr. Rajendra Seth, Venu has treated over 8.5 million people, a vast majority of them free of charge, in line with its founding philosophy. It now runs 5 eye hospitals. By the time Dr. Seth passed away in 1996 at age 56, Venu's mission had firmly been institutionalized. Nearly 3 decades later, furthering that mission is his successor and managing director of the Venu Eye Hospital, Tanuja Joshi, as India addresses its widespread problem of blindness, most of which is caused by the poor with cataract unable to access treatment. Tanuja says Venu keeps its focus on expanding access to the economically weaker Indians. She spoke to MCR from New Delhi.
Welcome to Mayank Chhaya Reports. Tanuja, it's a great pleasure to have you.
Thank you. Thank you for inviting me.
I want to start with something rather positive. I read that the World Health Organization has just validated that India no longer has trachoma as a major cause
Yes,
of
yes.
blindness. Tell me a bit about it and whether Venu, being an eye institute, what kind of role or perspective you have on that.
So, India had been saying that we don't have trachoma, but some years ago there was some sporadic cases that were reported. In
Hmm.
fact, Venu was part of the 2005-6 rapid assessment that the government did on trachoma, and but we're very happy to say, that finally WHO has accepted, because there was a lot of campaigning done by the Indian authorities to say that we really don't have trachoma anymore, and there had been some very sporadic case, but we are glad that now finally WHO has accepted that India doesn't have its eliminated.
Right.
So it's actually a very interesting day today, because it was only today that it came in the news.
Indeed, indeed. You know, trachoma is an interesting problem in the sense that it has things like poverty, hygiene, and other things feeding into it.
Yes,
Especially in the Indian context, I mean, it's India has been a sitting duck for any number of
yes,
reasons for that. So it is
yes.
especially remarkable that we no longer have it.
Absolutely, absolutely, because poverty is still there. Those issues, health issues, are still there. But I think something like polio, we have had a success story, and
Right.
it's interesting to see that this also has been successful as a campaign.
Yeah. I think
In fact,
people don't. Yeah, sorry, go ahead.
no, in fact, India, when it was the first country to launch one of the blindness schemes in 1976,
Right.
the National Program for Control of Blindness, and the initial effort of that scheme was for trachoma control. And so that part, we've done very well.
Right. People don't realize that it's a bacterial problem. It starts with that something that could be pretty quickly prevented or avoided
Absolutely,
altogether. And then it builds
absolutely,
up and finally it's irreversible, right?
absolutely. And it's also, it spreads. It spreads with touch. It spreads with hygiene issues, and so definitely we are very happy that at least that part we have been able to manage.
Right. To broaden our conversation a bit, India is home to 17% of the global population and accounts for 25% of the world's blind population.
Right.
That's an
Absolutely,
astonishing statistic in
absolutely,
itself. How do
absolutely.
you, as a major institute and hospital, look at something like that?
See, the problem is definitely lack of access. definitely awareness plays a part, but most of the healthcare facilities in India are in the urban areas. Now, of course, it's also going into the smaller towns, but most of the disparity of the population, majority being in the rural areas, and the services being in the urban areas, is one of the issues. And also, a majority of the blindness is due to cataract,
Right.
which is age related. And so the elderly and the children are the vulnerable segment. And in the rural areas, the elderly are not anyway given importance. So the problem is that so what the government, the three-tier network that the government has with the referral centers or the teaching hospitals, with the district hospitals, the secondary level, and the primary health centers at the, it's a beautiful scheme. It's a beautiful, the program. But unfortunately, in the government setup, in the rural areas, there are lack of resources, whether it's doctors, whether it's the medicine. So Venu has adopted a similar approach,
Hmm.
that we have our main teaching and referral hospital in Delhi. And at the second level, we have our 30-bed rural hospitals, which we call our satellite hospitals. And what we call the PHCs, we have our vision centers and camps. So
Right.
we have adopted a similar model. In fact, most of the eye care organization in India follow that. And now, see, when Dr. Seth started this in 1980, it wasn't such a structured thing. In those days, it was either the government hospital or trust hospitals. And all the trust hospitals across India have actually implemented a similar model.
Hmm.
Today, it is known and it is being taught as a subject of community ophthalmology, which is, the outreach model is become actually a model. But earlier, it was the response that, philanthropists responded to the situation, and it evolved as a three-tier network.
Right.
And that's the only way that we can reach the population in the rural areas. Yesterday we did a camp which was in Sonipat, and we had an OPD of about 100 patients who came, and we had 33 patients who were advised cataract.
I'm interesting you should mention cataract because I was again reading a statistic on that 66% and little more the blindness results because of cataract. Now,
Yes.
once again, it comes down to the fact of poverty. People with no money cannot handle cataract. It's a relatively simple operation, and as a major eye institute, I'm sure you deal with it all the time. Is
Yes.
there a national policy on something like cataract, for instance?
There is.
There.
There is. The government has a policy, but I think the government statistics say something like 62 lakh cases were operated in average. We average about 60-65 lakhs cases every year. That's hardly anything.
Right.
It's hardly anything when you look at the aged population in India. And the other sad part is that the other cause of blindness is just refractive errors. All we need is a
Right.
pair of glasses. That's
Yeah,
about
that's amazing. Yeah.
so it's about 19 point something, almost 20%. So 80% of blindness in India is avoidable.
And think about its economic impact. I mean, it,
Yes, yes,
so many people blind has a direct bearing on the country's economy, and yet, like you
absolutely.
said, the figures are nowhere near where they should be in terms of attending to this problem.
See, because the government, in fact, the WHO and International Agency for Prevention of Blindness had also started something called Vision 2020, a consortium that was supposed to focus. 2020 come and gone, but we're still struggling with achieving the targets.
Right.
And women, of course, and children are more vulnerable. That's, it's something that we deal with all the time. Men
Is
still
this
do have access, but women and children are still
right?
deprived.
Is this a cultural issue in the sense that we don't seem to be taking blindness that seriously? I mean,
See,
since you
tradition,
mentioned that 80% of blindness could be avoided,
yes.
and yet we have it. That means we seem to be rather
See,
lackadaisical about this.
see, 60%, which is cataract, unfortunately, with age, people feel that they won't see, they can't hear, they just accept things.
Exactly.
And I remember when Dr. Seth started, the work in 80, he would go and tell patients, Kine, I can give you sight back. And the patients were not reaching him. And then he realized, did I do a service or a disservice? He was happy, satisfied that with age he can't see, and now I've gone and disturbed him. So that's when he realized that no, I have to bring them myself because there's nobody to bring them. In the 80s, the patient had to come and stay in the hospital for 5, 6 days.
Right.
So there was nobody who would bring them. A person who would bring was an earning member. Women wouldn't accompany as a attendant. And of course, over the years now things have changed. So that's why in the past we would, and even we still do, we bring the patients in the buses, otherwise they will not reach us.
Right.
If we do a camp in the rural area and we tell the patient, this is the address, can you reach us? They don't come.
Right. I would like you to talk about Venu. You've been with Venu almost since its inception, and
Yes.
especially in the context of the extraordinary work done by Dr. Seth. Take me back to your history and tell me about its growth, because I've seen in the early days when I used to be in Delhi,
Yes.
but
Yes.
now you have several centers around the country and you are a major presence. So tell me about Venu.
So the genesis of the organization, of course, was the founder, who was a private practitioner doing very well. But at the age of 36, he had two massive heart attacks, and that was in the 1976. And in the mid 70s, his private practice used to yield at least 10 lakhs a year. So, he was very successful, and that's when he decided that I have to give back to society. And so he would go to the rural areas like I mentioned, tell
Right.
the patient come to my clinic, and he realized they were not reaching. So then he got a van and he started bringing them in the van, operating and taking them back, and that's how the camp started. But then in some campsites, patient would say, you didn't take us last time, there was no space, now you're again not taking. So wherever the need he felt was more, a clinic was established. And then from there, whenever the numbers increased further, then we converted them into a hospital. And that's how this three-tier network started. And then when you have this kind of a network, you also need human resource. You need doctors, you need the technicians to be there. How do you bring them? Because not everyone is willing to go. So then we evolved as a teaching hospital.
I see.
And when you're a teaching hospital, you do have the capacity to man all these hospitals. So for us, it was just a natural evolution in response to what the patient's need was. And that's how we have grown, and we've seen about 86 lakh patients to date, and we're very happy to say that over 55-60% of them are free of cost.
I see. That's a big number.
Because the mission of Dr. Seth was to reach the poor people,
Right.
and so we still have the focus is still to reach out to the poor patients.
Tell me about the combination that you've developed as a teaching hospital as well as something that does such vast charity. How do you manage funding? Because it takes a lot of money to do what you do. I'm curious to know how you managed to raise funding for this.
So in the earlier part, it used to be almost 80% free patients, and we used to get almost 80-85% donations and grants, and a lot of grants we were getting from overseas,
I
from
see.
Germany, from UK, from USA. Those were the countries because they were international funding agencies which were funding us. But somewhere in the 2000, when the recession hit the West,
Right.
we realized that the funding is dropping. And because the funding dropped, they also internationally had to take a decision. And they said India is now a success story in eye care.
Right.
And it, actually, in many ways, India is. So then, with the limited funding that they had, their focus shifted to both Africa and Bangladesh. So they told us that, now you have to start looking to do something yourself. So that's when we, as an organization, also realized that from doing 80-85% only free work, we also now have to start doing some paid work.
Right.
And because we are Delhi based and there are patients who can pay, so then we started focusing a little more on our own revenue generation. We started optical services, so we sell spectacles, we started a pharmacy, and then we also opened up to some of the teaching programs where the students would pay So there are two parts of the teaching program. One is a postgraduate teaching. There, of course, the students don't pay because that's an investment we make. But there are also practitioners who want to hone their skills. They're private
Right.
students, so we then charge them not a huge amount. So education, of course, doesn't get us a huge amount, but it does have some cross subsidy. Then, of course, we also go to the Indian donors,
Right.
which is not always very easy to
No,
get
it's
money
not.
out of. So we have been looking at our own revenue source. So now we are able to do 50% charity and 50% paid. So then we are cross subsidizing from the paying patients that we have.
Oh, I see.
We still have challenges because while we are able to meet our operational cost, we still have challenges when it comes to the technology being upgraded, like equipments to be bought, or now that we have this campus in South Delhi, maintenance of buildings. So these still continue to be a bit of a
Right.
challenge for us.
But your underlying philosophy still remains charity, right?
Absolutely, absolutely. Even though the government mandate to us is that we do 25% of our outpatient free and 10% of our inpatients free, because the land that we have has been given by government at a subsidized rate. But even the government has written officially that Venu is doing far more than what it is supposed to be doing.
I see.
Because as a philosophy, we want to keep it as 50-50.
Because I remember Dr. Seth initially, I mean, I did engage with him quite a bit. His entire fuel was compassion and charity. I remember it very vividly.
Absolutely. So we were doing 80% free work.
Right.
Today we had to, of course, bring it down. And in fact, Dr. Seth used to always say that, there may be a situation, increase your volumes. So if you're doing 100 patients, operating 100 patients, and 80 patients you're doing free, take it to 1,000 and make it 500.
Right.
So you move from 80 to 500.
Okay.
So there will come a situation that you may have to break even, because see, if you only depend on donations and grants, there is a limit to growth then.
Yeah. Given your decades-long expertise and success in this space, I was just wondering if you are in a position to go global, because there are so many countries, for instance, in Africa and elsewhere, they would need something like this. I'm saying if you were to consider the same model in Africa, wouldn't you expand your footprints
We
quite
would,
drastically?
in fact, we have done some work in the past, but that was when we have support from international agencies,
I
because
see.
that requires a huge amount of funds and funding. So we have done some kind of, with Bangladesh, with Myanmar, with
Yeah.
Nepal. We've done a lot of work in terms of training their doctors, in terms of going there, sending our teams for surgery. But unless we have some kind of funding for it,
Right.
it's that's just a bit of a limitation. We have the expertise, we have the experience, and we used to do it, but that was pre-COVID.
Right.
Post-COVID, we have not yet started it.
I see. Tell me, as the managing director of the whole institution now, what kind of challenges do you face on a daily basis? I'm sure by now you're a well-oiled machine after these many decades, but I'm sure that at the same time you have several challenges that you confront.
I think human resource, doctors, and the
I see.
technical team, because in the last 15, 20 years, a lot of private players have come, a lot of business houses have come into healthcare, and fortunately, or if
Right.
I look at it, it also is a challenge for us. So what's happening is there's a lot of eye hospitals that have opened up, and then they have these chains of hospitals. So every hospital needs a doctor, every hospital needs the optometrist and the paramedical staff. But the colleges, whether it's medical colleges or paramedical colleges, have not increased that much.
Right.
So the number of students that are coming out are being absorbed by these people because they pay them phenomenally, which
True.
we find a challenge to always.
Yeah.
We've of course improved much better we are, but that is still a challenge for us. So that becomes a bit of a problem these days, getting doctors and retaining them.
Yeah.
Because another thing, I mean, in India, gone are the days, at least in our generation where we looked at stability. These days, everyone is jumping,
Absolutely. Absolutely. Yeah.
and nobody wants to go to the rural areas. That's another problem.
Right, right.
So, so
Another challenge for you is that globally, the problem of blindness is in pockets. Say India still has Bangladesh. You mentioned Myanmar, Nepal, parts of Africa, but beyond that, the kind of chronic problem that you see in these areas you don't see elsewhere, and that perhaps limits your ability to raise funds, I suppose.
true, and then while cataract does get funding,
Yeah,
and even to some extent refractive errors, but then people are willing to pay for spectacles. The challenges that now we are having is with the longevity of life. The problem is the diabetic problems. Diabetic retinopathy is a huge problem.
right,
Also, the macular degeneration. In the US, of course, that is one of the big problems that they have. But even in India, longevity of life, and also the number of children who are now the premature children, their
right,
survival is much better. So these are challenges which are definitely there, and they're expensive.
right,
They're not like cataract. Cataract is, in that sense, a far more economical, problem to solve because you also get funding for it. But these are the challenges which are, and also the prognosis is very difficult to tackle.
right.
And
um,
so,
no, go ahead, finish it. Yeah.
so age-related issues are also now coming up, and India is a diabetes capital. So we have even far, and the unknown diabetics are far more. We did a project some years ago where we took two rural areas and one urban and one semi-urban area to screen for diabetes. And it's not that the rural areas didn't have diabetic; they were unknown diabetics,
Right.
which is even worse.
And people do not necessarily make the connection between diabetes and blindness. Even
No,
now, it just doesn't strike them the two are quite connected.
absolutely. And one of the first organs that diabetes will affect is eyes.
Exactly.
In fact,
Exactly.
what we are now working on is that because our mission vision statement is good sight and quality life for all. Good sight not necessarily gives you quality life, because there are other issues that you have. Today, if we treated you for cataract and you have diabetes, tomorrow your eyesight will get affected and quality life will get affected. So we are now started also a campaign to control diabetes,
I see.
and that also in an integrated way. It's like you continue with your medication, but naturopathy also helps. So we are bringing in naturopathy to help, because at the end of the day, we want, so because Venu has responded to the need of the patient always. So we find there is this need where if a person comes with diabetes, uh, he has to be helped to manage it, because only
Right.
then can our ophthalmologist do justice to the patient.
Right.
If you're
You know,
treating a diabetic retinopathy patient and he doesn't control his diabetes, the ophthalmologist can do just that much.
you've been around for like as an institution. It's all more than 4 decades now. How
44 years.
would you describe the way your interactions with successive governments have changed in terms of responsiveness to what you do?
I think we have so far had a decent relationship, because one is that we've always been apolitical and
Right.
secular. So, and I think the legacy that we have inherited, that 44-year legacy, whichever government comes, they respect whatever we do. And the reason is because we just work, and
Right.
we don't get into any this thing. So we have always had a good relation with any government that has come,
Right.
fortunately.
Dr. Seth was like that, and you've kept up that legacy. I mean, I know that for a fact.
Tried to, because I think I was just so raw when I came to him that he just molded me the way he wanted.
I remember it so well. It's all very vivid in front of me.
Yes, yes.
On that note, Tanuja, I want to thank you very much for your time. I'm
Thank you for
glad
it.
we did this. This is an important. I wanted the people here to know the work that you're doing. So I hope to some extent it makes a difference.
Thank
And
you so much, Mayank. Thank you so much for giving me an
oh, not at
opportunity.
all eminently deserved. All kinds of random people get time these days, so why not someone of substance? That was, I always try to do that on my little show.
Thank you so much. Thank you.
Thank you.